Good morning. Welcome to Coffee and Cases, everyone. See, there's still quite a few people joining, so we'll just give a moment or two while we're waiting for them. Just some reminders, so please don't put your details in the chat. I'm getting to the point where if you put your details in the chat, I think I'm going to delete your CPD points. So please make sure that you send the register and don't put your details in the chat. A register link will be shared towards the end of the session, and you will need the word of the day in order to earn the CPD points. Just also a reminder that the register must be completed before 12 o'clock today, otherwise the CPD points are not submitted. Also a reminder that we are trying to create a really safe space for really good conversation. Please share your experiences, please ask any questions, jump in with anything that you're interested or unsure about, and try and make it as safe and easy a learning experience as possible. We're going to just do a super quick reminder today that we are sponsored by Stat Medical. So Stat Medical is sponsoring this session. Thank you so much for their engagement. I don't know if Stan is on the call today and wants to say anything.
Thanks, Caleb. I just wanted to say thank you very much for the opportunity, and we're still very proud to be a part of it. Thank you so much.
Thank you so much, Stan. Your support is unbelievable. Today, we have a really cool interaction with Caleb Gage, who's going to be taking us through a little bit around some of his PhD research and some of the findings that he has managed to come up with around how palliative care might be integrated into an EMS system, and probably a lot more depth and information than my introduction. Caleb.
Thanks, Caleb. Just to start with, can everyone hear me all right?
Yes.
Yes, we can hear you, Caleb.
Caleb, are you currently muted or are you not?
Oh, there we go. Now, am I back?
Yes, sorry, I just muted everyone and then I see you also got muted. My bad.
Okay, cool. And you can see my screen, eh?
Yes.
Awesome. Yeah, well, good morning, everyone. It's a pleasure to be back here on Coffee and Cases. I've had the privilege of presenting here once or twice previously on this topic of EMS and palliative care. And so today is really just a continuation of the discussion that we've been having on this topic. To date, we have discussed the concept of EMS and palliative care. We've discussed some research findings, but now today is really the practical bit, the how-to of integrating EMS and palliative care in South Africa. And as we start, I just want to emphasize that this presentation today is for everyone. It's not just for managers and policymakers. It's even for the individual provider. Wherever you work, in whatever situation you find yourself in, you really can be a part of integrating EMS and palliative care in your workplace. So this is applicable from individual provider all the way up to policymaker and everything in between. But for those who perhaps did not join previously and who don't know me, my name is Caleb. I'm a paramedic by profession. I'm currently working at the City of Johannesburg EMS at as a program manager at our training academy. And as you may have gathered, most of my research has focused on integrating EMS and palliative care within South Africa. So what I'd like for us to do today is just review what we have covered so far in previous presentations. So we'll just recap the palliative care definition. I always find that's an important place to start because misconceptions about palliative care abound, particularly amongst those involved in more curative forms of medicine, such as the EMS. Then we'll just review why we are talking about this in the first place, and have a look at EMS and palliative care intersection and what the two have to do with one another. And then we'll just review the benefits of integrating these two very distinct and yet complementary systems. Then we'll get into the really practical bit. We'll look at the conceptual framework for integration that has been developed specifically for the South African setting. We'll look at the methodology of how we did that, and then we'll get very practical in terms of an implementation strategy that we can even today go back to our workplaces and hopefully use. So to just review the definition of palliative care, the WHO has defined it as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So as you can see from that definition, it's pretty broad. Some of the misconceptions about it are that it is only for end of life, or that it's only for cancer patients. And another big misconception is that this is sort of a last resort. So we only implement palliative care if our curative care hasn't worked. Then we make the switch over to palliative care. That may often happen in practice, but it's not actually appropriate, and it's not actually what palliative care is designed to do. So palliative care actually works at its best when it functions alongside curative care, when it is initiated early on in the disease trajectory. So it's certainly not opposed to curative care. It is a very different type of care in and of itself, but it's not opposed to curative care. In fact, the two are designed to work together. However, as we do know, as patients do approach end-of-life situations, palliative care begins to take a greater and greater role as perhaps the curative care starts to take a lesser and lesser role. So that's how the two should be working together. So we can see that this includes any chronic or life-limiting illness. It also includes end-of-life care and any condition, be it physical, psychosocial, or spiritual, that may cause suffering. So quite a broad and holistic approach that palliative care takes. So what does this have to do with EMS? Well, it has been estimated globally that about 2 to 10% of annual EMS caseloads involve palliative situations. And we've argued in our research that that is likely quite a bit higher in South Africa because of our greater disease burdens. Remember, we have what has been termed a quadruple burden of disease. So we have much greater disease burdens here compared to the higher income countries where these estimates have been created. So as a result of those increased disease burdens, we have increased chronic illness, therefore increased palliative care needs, and therefore greater EMS contact with those needs. So there is quite a significant intersection. So in one South African study that we performed, that illustrates this, we looked at 2 hospitals in the country that had palliative care units. We studied those units for a 1-year period, and we found that those 2 units managed 1,207 patients with palliative needs. And of those, 33% made use of EMS to arrive at the hospital. And they did so on 494 occasions. So what that means is that many of these patients used EMS multiple times during the course of the year to arrive at these facilities. And that makes sense because we know that patients with palliative needs have very complex illnesses, and they are often very unwell, and so they do need to make use of EMS quite regularly on occasion. And so that resulted in an average of 41 EMS transports of palliative cases per month. In fact, at one of the hospitals, if you just studied the one hospital on its own, over 50% of their cases arrived via EMS conveyance. So quite a substantial intersection, and even those numbers probably don't quite capture how frequent the intersection is, because of course we only used 2 hospitals within one area of the country. These numbers do not include non-conveyance, so any patients who are left at home. They also do not include situations where death already occurred at home. So the intersection is likely even higher than what we've indicated in this study. We know, for example, that in terms of emergency cases in South Africa, those only make up between 10 to 20% of our calls. So the other 80 to 90% is made up of palliative care, primary health care, and minor injuries and illness. So there is certainly substantial intersection. And as a result, that means that palliative care becomes relevant to us. So what are the integration benefits? Basically, these are the main ones. Improved patient and provider satisfaction. There's a nice Canadian study that demonstrated that. And the improved provider satisfaction is really an interesting one, because the paramedics who were tested in this way said that they found it to be very meaningful work when they were part of a palliative care team and managing these situations, which is quite interesting because these situations are very different to the emergency situations that we often talk about and that we often work with. And I think, one of the reasons for that is that at the end of the day, and I'm sure I can speak for most people here, but at the end of the day, we all really do want to make a difference and truly help the patients that we see. I think sometimes that gets lost along the way. We can become very callous. We deal with really hectic and stressful situations on a day-to-day basis, and sometimes I think that can just numb us a little bit to the job that we're actually meant to be doing. So I think one of the reasons that palliative care creates such increased satisfaction is because there really is a sense that you are making a difference. It's really evident that you are meeting these people's needs. And I think that's quite meaningful to us, and perhaps something for us to remember as we go about our day-to-day work. So perhaps palliative care could be meaningful to you as well in whatever situation you find yourself working in. Then increased quality of life for patients and family members, improved palliative care access, because where EMS and palliative care services are integrated, EMS can arrive at an incident and link these patients with the appropriate form of care. They can link them with palliative care services. And so that's very important as well. And then increased healthcare efficiency. So where EMS and palliative care are integrated, that tends to result in decreased unnecessary transport to an emergency department, as well as decreased admissions and therefore decreased associated healthcare costs, while at the same time improving the quality of care that these patients receive. So improved healthcare efficiency is quite huge and quite a major difference that we can make through this integration. And then right there at the bottom in big bold letters, I've put that palliative care makes better paramedics. And that's really been, throughout all of the research, that's been a revelation to me, is that palliative care does not just make paramedics better in palliative situations. It makes them better, it makes us better in any situation that we come across. And so what I'm presenting to you today is not necessarily just for the sake of improved palliative care. It's also for the sake of improving our practice wherever we are. And I think the reason for that is that palliative care is focused on person-centered healthcare, and we'll dive into that in a bit more detail. But person-centered healthcare is the goal, and that should be the goal for us as well. And so where we allow palliative care to influence us in our practice, we start to provide better healthcare. And I don't know if you've realized this, but in the EMS, we are part of the healthcare system. Unfortunately, sometimes it seems like, I don't know if I should say this or not, I'm going to say it, but unfortunately, sometimes it seems to me like we're more part of a tow truck business than the healthcare system. And that's unfortunate, but I think palliative care might be able to change that for us, might be able to just renew our perspective in terms of healthcare. Because, for example, if you're at the scene of an MVA, palliative care principles will make a difference in how you approach that incident. If you've got enough hands to be managing the critically ill patients on that incident, and you've got other hands available, which we often do, to come alongside the families, the distraught family members who are on that incident, and just chat them through what's going on, and explain to them and involve them in what's happening, should they be willing. That is improved healthcare, and that's what we should be doing. Instead of chasing the family away and saying, we're working here, please, we're busy, stay out of the way. Maybe let's try and help them as well. They are also suffering through this. So palliative care makes better paramedics. And I hope even by the end of today, it will do that for some of us in this meeting. Well, so much for the recap. Moving on towards the conceptual framework and the practicalities of integration. This little diagram here is just the methodology that we used in creating this framework. So you'll see each of these circles represents a separate study that we performed, and all of these were performed in South Africa. So what that means is that the framework that I'll be presenting to you is South African in nature. It is designed for us here in our country. It is evidence-based with South African evidence, and that is quite important. So very applicable to our setting. Although I would like to think it might have some international applicability as well. So if you just look at the largest outer circle there, that was a scoping literature review that we performed. We found, I think it was just over 50 studies that we looked at from the international literature base. And that really just provided context for the overall study. So we took those findings into account for our context. We then performed several qualitative studies. So these were interviews with the primary stakeholders involved in this discussion. So you'll see at the top there, that involves EMS providers that we interviewed. Then we interviewed palliative care providers, and we also interviewed patients and family members, all to get their different views and perspectives on EMS involvement in palliative care. And what was great about those studies was that each of those stakeholder groups viewed that interaction positively. They viewed integration between EMS and palliative care in a positive light. And then at the bottom there, the bottom circle, we did a retrospective chart review that provided the quantitative data for our overarching study. And that was actually the hospital study that I've mentioned previously, where we looked at those 2 hospitals with palliative care units. And then you'll see all of these arrows just indicate which studies informed which other studies. So all of these studies then informed a nominal group technique study there in the middle, which is basically a method for expert consensus. So we got experts together from both EMS and palliative care sectors to discuss all this research, to develop some novel ideas as to how we can integrate EMS in palliative care. And so as a result of all of this study, this was the final product. So this is the conceptual framework for integrating these two systems in South Africa. Now, there's a lot here, but we'll dissect it one element at a time. If you just look at the bottom, you'll see there's this thing called complex adaptive systems. Now, that is basically a theory of healthcare that underpins our model here. But it's a theory of healthcare that views healthcare systems as more like a living organism than a machine. So, if the healthcare system was simply a machine, you could provide certain inputs into the system, and then you would get the expected outputs. But living organisms are not quite like that. They're more complex, they're more dynamic. And we know that healthcare systems are complex in nature. They are full of intricate, interwoven parts. So what that means is that if I give the healthcare system a certain input, I might get a completely different result to what I expected, because it's a living organism that's constantly adapting to different changes in its environment. So that was the underpinning theory that we used to create this model or this framework. And what that practically means for this framework is that we were not looking here for solutions to the problem of EMS and palliative care integration, because solutions imply a one-size-fits-all approach that will fix the problem. And problems in healthcare tend to be a bit more dynamic than that. There's no one-stop shop. There's no one-stop solution. So rather than trying to find ultimate solutions that we can enforce to cause integration between EMS and palliative care, what we wanted to do was rather create an enabling environment, create a positive environment within which integration can occur. I hope that distinction makes sense and is clear, because it's quite important. And what that does is it allows the healthcare system, including EMS and palliative care, it creates an environment where they can somewhat naturally adapt towards integration. And so that's quite an important distinction between that and a machine view of healthcare. So that was our underlying theory that we used. Then if we just zoom in straight to the middle there, that says person-centered care. That is the goal of this integration. That is the bullseye of this framework. That is the aim of palliative care, and it should be the aim of EMS as well. So that's really what we are after. And just to define person-centered care for us quickly and zoom in on that, this is the definition. An approach that consciously adopts the perspectives of individuals, families, and communities, respects and responds to their needs, values, and preferences, and this is really important, and sees them as participants in their own healthcare rather than just beneficiaries. That's incredibly important. And again, I think that's something within the EMS that we really get wrong. We have this tendency to approach cases as if it is the patients who are privileged to see us, rather than us having the privilege of participating in that patient's healthcare. That's such an important mindset shift for us to take. It's not just patients who are privileged to receive some healthcare. We have the privilege of entering into that healthcare as a partner with them in their management. And that's so important for us to understand. And again, that's what we are hoping that this integration between EMS and palliative care achieves. So back to the framework here, if we just zoom a little bit further out beyond that person-centered care, we see that circle there labeled an enabling environment for integration. That is what is related to the complex adaptive systems there. And what we are saying is that this enabling environment will ultimately result in improved person-centered care. If we zoom a little bit further out then to sort of the colored section of this framework, we see that there are 4 main categories by which we can integrate our services. So we've got empowering and engaging people, reorienting the model of care, strengthening accountability, and coordinating services. So those are the 4 main categories, and those come from a pre-existing WHO framework. Tell me if you think this sounds relevant, but this was from the WHO framework for integrated person-centered care. So it really fits perfectly with what we're trying to do, and that's really why that pre-existing framework was chosen as the skeleton, if you will, of this framework, just because it fits perfectly with what we're doing. So those are the 4 broad categories that we've based this on, the WHO framework. Then if you zoom out a little bit more and look at the different subcategories, if you will, of areas for integration that we've attached here, we'll go through each of them just briefly to see what we're talking about. These are the subcategories that came out of primarily, well, all of our research, but then they were organized into these categories through that final expert consensus study that we performed. So if we just start at the top there by empowering and engaging people, and we look at education, that was highly recommended in all of the literature, really, as you can imagine, and it was recommended at all levels. So when we say education, we're talking about primarily palliative care education for EMS, although some EMS education for palliative providers might also be helpful. But this was at undergraduate level, at postgraduate level, and even ongoing CPD activities, kind of what we're doing this morning. And then we've got community engagement. And this is important because you want to establish the community that you're trying to serve. You want to establish what their actual needs are. You know, if our aim here is person-centered care, community engagement needs to be present in some way, shape, or form. There's no point trying to achieve person-centered care if the people we're trying to provide that care to have no input. So that's an important one. Then we've also got awareness. And that's such a simple one. You know, anyone can do that. Anyone can spread awareness of what palliative care is. Anyone can spread awareness of how palliative care relates to EMS and how EMS relate to palliative care. So it's just a really nice, simple one that we can do. And again, the nice thing about this Coffee and Cases platform is that we are already achieving elements of education and awareness right here. So that's really, really great. And perhaps you find in your situation where you are working that maybe that's all that you are able to do with the resources you have. Perfect. That's great. That's what this framework is for. Identify areas that you can use that are relevant to your context and take it forward. Then over to reorienting the model of care. Now we've got a couple there. So alternative pathways and approaches. So that really what that means is allowing the EMS to function a little bit differently. So for example, allowing us to not transport some patients and maybe leave them home, or even transport patients to alternative facilities. Is there any reason that we have to go to an ED? Why can we not go to a hospice? Why can we not take a patient from hospital to home? Why can we not even take grandpa from one house to another house on the other side of Johannesburg so that he can be closer to his family? We've got the capability to do that. There's certainly a need for that. I don't see any reason why we shouldn't be doing that. So that is part of this discussion as well. Then funding, hard to get, but of course also always useful. But the other element of funding that we picked up on here is that we need to relook at the funding model for EMS in terms of how EMS are paid. It tends to be the case that EMS are only paid if you transport a patient. So particularly within the healthcare sector, that's a big barrier to integrating EMS in palliative care, because often these patients don't want transport and they don't require it. So that needs to be re-looked at, and that will probably require higher level discussions with medical insurance companies and so on. But it is certainly a part of this integrative framework that needs to be addressed. And then at the bottom there, strengthening accountability, we have a section for research. Of course, there's always a need for more research, but the specific research that is needed in South Africa still on this topic, we need to implement some actual pilot studies. We need to implement cost effectiveness studies. And then we also need to develop curriculum. If we are going to teach EMS about palliative care at undergrad level, what do we teach them? So that still needs to be developed a little bit more formally. And thankfully, a couple of these things are happening at the moment. There's a recent project that's starting to get underway now in terms of curriculum development. So that's happening. And then there's also somewhat of a pilot study happening within the Western Cape government EMS, where a palliative care desk is being established within their call center. So that desk can basically provide guidance to patients, families, EMS providers who are in these situations. So some of these things are underway as we speak. Then in terms of governance, this is primarily looking at a macro level intervention, a national level policy making level, where basically we would like to see EMS and palliative care integration start to be included in those discussions as well. And related there now to policy development, if you think of the NHI, the NHI bill doesn't really mention EMS. I think we've maybe got one line at most in that bill. And palliative care, I think, is also mentioned a little bit, but there's nothing about the integration between the two. So if we could advocate to have this form of integrative healthcare introduced and spoken about even in the NHI, that would really go a long way to having our services integrated. Then over at coordinating services, these ones are interesting, communication and information sharing, stakeholder collaborations, because they can be really simple. It could look like just having a cup of coffee with your local hospice nurse. It could look a bit more complicated and having high-level discussions and MOUs signed between EMS and palliative care services. But they are quite important for EMS and palliative care services to link up and discuss the needs and so on. Now, if we zoom out just to the large purple someone's taking over.
All right, yeah.
Sounds like an interesting conversation. Can you still hear me?
Yes, we've got you, Caleb.
All right, cool, thanks. So that final largest circle in purple there is the local context. Because, of course, this was quite clear in the literature and it's quite intuitive. You cannot really integrate these services outside of contextual factors. Even within South Africa, the different provinces among us have different EMS resources available, different palliative care resources available, and therefore they have different needs, and they would then have different goals of care and what they're trying to achieve here. So local context is very important. And that's also what is nice about using, again, this complex adaptive systems approach to this framework, is that it allows this framework to be adaptable to certain contexts. So it doesn't matter what context you are in, you can use this framework as a starting point. And again, we'll look a bit more practically at how to do that. But local context is very important. So that is the conceptual framework. I hope it's helpful. but it may still seem a little bit abstract. So what I'd like to do now is just to start to get more and more practical as to how we can go about implementing this. And again, remember, we've said that this is for everyone. If you are an individual provider, all the way up to policymaker, take what is relevant to you and implement it. It's possible to do that. And this framework is designed for that, to be flexible in that way. So here are the steps that we've recommended. It's interesting actually. This complex adaptive systems approach and talking about creating an enabling environment, I think it often makes us in the EMS uncomfortable because it seems a bit nebulous to us, I guess. We prefer to have an algorithmic approach. We prefer to have protocols and say that, okay, in situation A, I need to do 1, 2, 3. That's not really how good healthcare works, unfortunately. So here are some steps 1 through 6 that we can do to practically implement, and maybe that will help us within the EMS feel a little bit more comfortable. But in the first place, we need to perform a needs assessment. And again, that's within your local context. Is there a need for this integration? Have we engaged the local community? Step 2, we're going to assess our resources. What is available in terms of EMS and palliative care resources to meet this need? And again, if you have a ton of resources available that you can go ahead and change your funding and governance models, that's fantastic. Go ahead and start doing that. But if that's not the case, if you have almost nothing except you and a friend available as a resource, as a human resource, educate yourselves. Start spreading awareness. That's also part of this integration. And it's such a simple thing to do. So assess what you are able to do and start with that. One of the things about this framework is that there is nothing here that is necessarily more important than the other. That is completely a local context decision. One thing in one context might be way more important than another. So any and all of these can be equally important. Then step 3, it's helpful if we can to establish a team. This was one of the findings that was recommended in the literature, was to identify EMS palliative care champions who are passionate about this project, about this topic, and who really want to make a difference in that way. And maybe they can be the ones who take the lead on making these differences within your organization. Step 4, developing shared goals. That's important. And again, if we go back to the framework here, we see that those shared goals were part of the local context. So what that means is that these goals will probably differ from context to context. Again, there is no one-size-fits-all approach to integrating these services. It is very much dependent on the context that you are in. And I think that is a strength of this kind of framework, is that it can be applied in such diverse contexts. Then once we've now basically established our team, identified our goals, our local contextual factors, we can now develop an approach. Step 5 there, develop an approach. And this is where we can now look at this conceptual framework and say, okay, which elements are perhaps already in place? Which ones are we missing? Which ones are feasible for us to actually use? And which ones perhaps are not so feasible that maybe we just ignore for now? Or maybe we develop a bit more of a long-term plan to get to them. That's the idea. So then you can use this framework to develop and tailor-make an approach that is reasonable and relevant to you and to your community needs. And then step 6, continual monitoring and adaptation. Of course, we want to ensure that our approach is safe, efficient, and actually beneficial in our contexts. So that's important. But then also, you can adapt your approach as needed. As things change, as community needs change, for example, you can adapt your integrative approach to go forward. So again, just to emphasize, there is not a single approach which we are saying, okay, cool, now my EMS and palliative care services in my environment are integrated. Integration actually requires a little bit more work than that. It's not just a checkbox exercise, it's an ongoing project integration. There's almost no such thing as fully integrated. It's on a sliding scale, if you will. And the challenge is to now identify what level of integration would be appropriate for us, and then to try and keep it there. Because once it's there, because the healthcare system is complex and continually changing and adapting, we need to be able to adapt with it. So adapt your integrative approach as necessary. Now, if I can get even more practical to finish off this presentation, these were the top 5 very practical approaches that were ranked by our expert consensus panel in terms of what can be done. So these were ranked as having the highest impact for integration, as well as being the most feasible. So in other words, they're the most realistic things that can be done right now today. I mean, look at number 1 and 2 there. It's awareness, palliative care awareness for the EMS community. Simple as that. That will have the most impact for integration in the country. And if I can give a bit of an anecdote, I mean, that has been true for me. The only reason I've done all of this and got involved with palliative care was because at some point along the line, someone made me aware of palliative care, and I latched onto it. And so it's really, really awareness. It's such a simple thing that we can all go and do today. And then number 3 there, enabling EMS to administer already prescribed medications. So if you have a patient that's at home on oral morphine, don't put up an IV line and give morphine unless that's absolutely necessary for some reason. Just help them take the morphine that they already have, or whatever other medication. That's okay. Then EMS undergraduate training, we've mentioned. That will make a big difference. And that really makes a big difference because from the get-go at undergraduate training for EMS, if we can have students realizing that there is more than just curative EMS care, that would be a huge win. Because that's, I think, one of the biggest weaknesses of current EMS education is that we aren't even taught that there's other possibilities to care. We are purely taught this emergency curative care, go, hectic things, what power calls, whatever. That's all we know, which is unfortunate because healthcare is so much more than that. And then improving EMS recognition of the signs of dying at the end of life. And attached to that is just recognizing different situations, recognizing that not every situation is an emergency. Not every situation should be managed in the same way. So perhaps a practical education approach there. So in closing, I just want to again reiterate that have a look at your local context. See what in this framework is relevant and feasible for you. Latch onto it and go do it. Achieve it. Even things as simple as creating awareness of palliative care can make such a huge difference in your organization. And it's not even something that is formal. It's not even a formal integration process. But what awareness does is it allows the healthcare system to naturally adapt towards integrated care. So just finally, there are some resources here. I don't know, perhaps I can share this slideshow with Caleb and it can be distributed. I'm not sure, but if you would like any other information, please do let me know. I've put a couple links there to all the studies that we've looked at here, as well as links to some palliative care resources. And just to zoom in on the last one there, Patch SA, they've got some really nice online courses. The one of them that is an introduction to palliative care principles, that is free. So if you are interested in this topic, please do go have a look there and educate yourself. But thank you everyone for your time this morning. I'm sure there's plenty of time for questions and so on, so I'm happy to go ahead and answer those.
Thank you, Caleb. What an amazing presentation, just from the culture point of view. I think if I can just maybe highlight the comment that you made around palliative care makes us better practitioners in every direction. And I think being super aware of that makes us better. Just by being aware of the fact that we can be better is a good starting point. I see there's a really nice question, or some questions on the group, so I'm going to just read out one from Walter. So Walter says, the sending the family away can often work against us when the prognosis has become poor. We should be taking them through the process and our interventions, which I think just aligns really nicely with what you said. Mike Keller has asked or said, I think it's a brilliant idea to incorporate palliative care into EMS, but not sure how this will affect the qualifications. So looking at the different qualifications, only ECPs are permitted to discharge on scene. How do we integrate that and the scope into these palliative care discussions? I don't know what your thoughts are.
Thanks, Mike. Yeah, it is a really good question, and it's one that has come up fairly frequently. So the first thing to say is that from the research point of view, it's fairly broadly agreed upon that palliative care integration does need to be for everyone. It shouldn't just be for ALS, certainly shouldn't just be for ECPs. So it is very important that it's integrated at every level. So you're quite right, about things like on-scene discharge. That's a limitation for other HPCSA registrations. Although I will say, to be honest, even ECPs aren't exactly doing that at the moment. But it will probably look a little bit different for each qualification. So sure, you take the ALS qualification, for example, we might be able to administer that oral morphine at home or administer more medications. But where we can make it applicable to those with a smaller scope of practice, one of the biggest things that we can do for BLS, ILS, and so on is to just help them identify that this is a different situation. That would be the biggest thing. If you can just identify that, hey, this should not be managed according to my normal emergency EMS protocols. I actually need to maybe phone someone for assistance. I need to connect this patient with a different type of care. Just getting that awareness and recognition is so important and would make a really, really big difference. So I hope that makes sense. In terms of palliative care curriculum development, that will be involve ongoing research into what exactly would be taught at each level. But certainly, just to emphasize that every single qualification should have a role to play.
Awesome, thanks, Caleb. There was some really nice other questions just around, is there reinforcement available sort of pertaining to the law regarding do's and don'ts in palliative care and DNR orders or do not escalate therapy orders? So I think the person, I think it's Pierre, is looking for maybe a little bit of structure around what are the rules and how do we work within the rules around these things that we may be not always working with.
Sure. Yeah, also a good question and something that does arise often. Interestingly, when it comes to DNRs and
Koffie asseblief.
well, I also want
sorry, guys,
coffee.
if you're not asking a question, please just mute yourself.
Rudy, can they make me coffee as well? Thanks. But yeah, so when it comes to advanced directives, things like that don't have a let's just say they don't have an actual specific legal status. That can cause a bit of confusion. And what I will say is that our tendency is to just ignore them and say, oh, they're not legal documents, so I'm not going to listen to them. My protocols will therefore override your wishes. That's unfortunate. So they shouldn't be completely disregarded, because although they might not be specifically mentioned as legal documents in the law, they are lawful, and so we should take them into account. And what that might mean in terms of working with them when we do come across them is, again, perhaps just phoning for some expert consultation and advice and documenting those findings, and then working together with the family. Remember, we said that they are participants as well in their healthcare, and that's right, they should be. So we just need to include them and work together with them on it and have a discussion with them about it. Interestingly, there is a meeting happening tonight, as it turns out, where a group of EMS palliative care emergency physicians are getting together to take this discussion forward and try to get things like DNRs, advanced directives, living wills, to get them full legal status in Parliament. So I'm in that meeting tonight. I can let you know how it goes. But that discussion is being taken forward. Another thing just that relates to these first two questions that might help provide some clarity is, one of the biggest questions when it comes to EMS and palliative care is what is the actual role of EMS? And from our findings, we recommend that the role of EMS in these situations is actually pretty simple. It is to, number one, identify that this is indeed a palliative situation. Number two, to perform any immediate stabilization that is required, or as the palliative care providers like to call it, they say containment. So just to contain the situation. So for example, if there is really severe dyspnea going on, okay, let's try and sort that out. Let's give some oxygen, maybe some beta 2s, whatever we need to do, and help calm that breathing. And then number three, we need to now link that patient with the appropriate care. So in other words, ideally, we could end up taking that patient to a hospice, or just getting some consult and advice and end up leaving that patient unseen. Now, how you would get around that could be a little bit tricky. But again, even something like we currently have, like an RHT at the moment, could work, because I guarantee you a lot of those patients are literally refusing. They don't want to go. So an RHT could be a good enough legal starting point for that kind of thing. So that's really the role of EMS. Identify the situation, provide initial containment, and then link that patient with the appropriate care.
Lenoy has also asked, do you think it would be a good idea to incorporate social workers or counselors into the process, as often families are in denial or haven't been explained properly? And I think if we go back to the previous palliative care conversation, we really spoke quite a lot about this, thinking that we as EMS need to be the one-stop shop, but we really don't. And I think you've brought it up quite nicely, is we need to be the entry point, and we need to be able to point the patients and the patients' families in the right direction to get the help that they need. I don't know if you have any further comment on that.
Yeah, absolutely. And perhaps just to add that even a typical palliative care team is multidisciplinary, including allied health services and things such as social workers, religious ministers, all those kinds of things. So palliative care teams can actually become tailor-made to specific patient needs. Yeah.
Awesome, thanks. Then I see Bernard has just made mention of the fact that he works in quite a small service, in a community-based EMS service, where some of the toughest calls are those patients who are end of life or are not for resus. And the end of life discussions are usually not started early enough and don't get to the tough parts. We don't leave the tough parts right at that moment of decision making, rather have those conversations a little earlier.
Yeah, absolutely. It is helpful to have those conversations early. This is also where, for example, a proper legalized status for things like living wills would be really helpful to us, because then we could arrive on scene and manage those patients according to their wills and advanced directives and so on. And those need to be established early. on that, one thing also that the awareness of palliative care has done for me in my clinical practice when I have come across these kinds of cases is that I can actually be the one to initiate these conversations where I feel comfortable and where it seems as if the family would be comfortable as well. Of course, I don't want to just make the decision. In a very real sense, you need to read the room. But sometimes I've been able to have that conversation myself and say, hey, have you considered palliative care or hospice care, or perhaps getting a home care nurse? Because that would really be beneficial. And you'd be surprised at how many patients are so open to that and saying, oh, is that even an option? I didn't even know we could do that. And so you just through talking to them, just through identifying the situation and having a chat with them, you can really set them on an amazing trajectory for their care that will be so much more helpful than ending up in an ICU somewhere and dying 3 weeks later after racking up hundreds of thousands in debt for the family. So yeah, perhaps where you can, start having these conversations yourself where you feel comfortable.
And then just another question from Danielle. Is it possible that when you start end-of-life care, you might be mistaken regarding the extent of the condition or lack thereof, and they could maybe recover through pre-hospital or in-hospital intervention? I think this question really highlights the point that you made a little bit earlier, that it's not one or the other. I don't know if you want to maybe comment on that.
Yeah, so a good comment, and that has happened already, unfortunately. But perhaps two things on that. The first is that it should not be up to us in the EMS to implement end-of-life care. That would be inappropriate, because again, that would be us completely on our own making the decision. And you see, this is one of the mindset shifts that we need to have in EMS, because we're so used to this. We are so used to just being the ones. And that's how, on an emergency scene, that's how it happens. You are the guy or the girl, or you're the person. You need to make the decision yourself. And there's no one there to help you. Even if you wanted to phone, it's not a possibility. So we're so used to that, but in these situations, it's inappropriate. So we will never be the ones to implement end-of-life care. That requires a multidisciplinary team. So again, our role there would simply be to identify that, hey, this is a patient with palliative needs. I think they might be towards end of life. Let me get on the phone and get some advice here. And interestingly, when that has been done before, sometimes it's the palliative care providers who tell the EMS, no, you need to bring that patient to hospital. Remember, as much as we're talking about leaving patients home and so on, sometimes hospital is the right place, because there are certain conditions that are grouped and called palliative care emergencies. That is a whole separate discussion that we are not trained in at all, not even in the identification of them sometimes. And so we need to avoid that danger of implementing something like that ourselves, and rather just be part of a team, present our findings to someone else within the team with the expertise, and then make a decision together with that consultation, with the family member, with the patient, and decide on an appropriate way forward. I hope that answers that question, and I hope that would avoid any potential harm that could happen to patients if we miss something. Which I also don't know if you realized, but in the EMS, we are prone to miss things.
Sean Groom is just asking, what are your thoughts on using telemedicine to provide guidance for both family and teams in these environments?
Oh, I love it. I love it. It's such a great tool, and I wish there was more of it around. It provides such comfort for patients and families. It provides such comfort for EMS providers, because like some of us have been talking about here, these situations are difficult. They're stressful. We are out of our comfort zones. We don't know what to do. We could really use that guidance. And it would also allow us to actually access a team that could help us in that decision making. The other cool thing from a systems point of view is that a sort of telemedicine or advice line model is not necessarily a high cost intervention. It doesn't necessarily take too much depending on how you do it. So it could be one of those, we recommended it in one of our studies as a high impact, low cost intervention. So I think it would be fantastic for our setting.
Yeah, I think especially in spaces where resources are kind of central and patients are not. There's patients all over the place who need assistance that we just can't get them access to if you're going to wait for someone to come to them.
Yeah, exactly.
So just a few people just reflecting some of the thoughts and ideas that sometimes it's really difficult. These end-of-life events are really uncomfortable. Multidisciplinary teams are really important. And then Danielle's just made another comment around finding EMS environments a little bit more challenging than the private environment. Have you looked at this at all in your study to try and figure out how the sort of government and private spaces could do things better and maybe how it might be different for each of them?
Yeah, so I do agree to the extent that government EMS, it's much harder to change anything. It's a much slower bureaucratic process. So that is a challenge. Whereas in private EMS, especially where there is financial incentive, we can make changes. And when I say financial incentive here, I'm not talking about that in a negative light. Obviously, the services need the funding to run. So that's where, perhaps we can start having discussions with the medical aides and so on and implement these different types of change while the EMS are still able to function and are financially viable. So certainly different. And yeah, there's probably a lot more that could be said on that. But certainly the framework that I presented today is worth is valuable in both government and private. So again, take what is implementable in your situation. So also in government, if you want to change things like funding models, going to be very difficult and lengthy process. But one big thing that can be done within the government setting is just changing attitudes, spreading awareness of this type of care, and really emphasizing the need for person-centered care. And I think once we start getting that attitude right, perhaps other changes can come along. I see, sorry if I can take over, I see Louis put his hand up. He wants to say something from National.
Good morning. Thanks, Caleb. I don't know, Caleb from Rocket, can I go ahead or should I give you guys some time to continue with the other questions?
Please go ahead.
Sure, thanks.
Go for it.
So first of all, I think it's a really, really great presentation and you really gave us I almost want to say, implementable overview of what needs to be done. I just have, it's not really questions, it's just some comments, but on that stepwise kind of algorithmic approach that you've showed us, I almost want to say, for those sitting in public EMS, you are sitting in the ideal position. And this is from a systems level. If you haven't noticed that you're often sitting within a chief directorate where you are aligned with all the allied healthcare professionals. So you'll have the nurses, you'll have primary healthcare, you have the community-based healthcare workers within your management structure, which is a bit more difficult if you in the ambulance seat, but in the management structure and the systems kind of changing way, you've got an ideal platform to do that. And similar for other committees like the provincial pharmacy and therapeutic committees, which is existing in each province. And those are the guys that's making the decisions around which medications can be used, what are we allowing within our system, and those kind of things. So from a awareness point of view and those steps of doing stakeholder consultation with your direct stakeholders, as in other healthcare workers, we are sitting in the ideal platform to do that. Similarly, public sector as well. And I agree with yourself, Caleb, that it's probably a little bit easier in public to have that conversation. But people sitting in public sector definitely has the right role players on their doorstep. I think it just starts with it just starts with the awareness part of that, and then also actually saying, hey, we can potentially help you alleviate the load in some of your other settings, because currently we're just bringing all those patients into the EDs, whether that is in a whichever kind of ED that is. And then I kind of just made a note as we went through the presentation. I think one thing that is important, and it's surpassing just the palliative care thing, is when last as EMS, and I actually want to move away from the word as EMS, but when last did we as ambulance services ask our clients what they want? And I think it comes in with what you mentioned about the stakeholder consultation and actually asking, what do you want from us? Because anecdotally, I can promise you that we're not delivering the service that they want. They don't want red lights and sirens all of the time. They want different approaches. And I think that's where it comes in with the alternative care pathways. Lastly, to end off, as much as a lot of the work has been done, and I think some of the questions alluded to it in the chat, is there's going to be a lot of system reformation that needs to happen going forward, and that's with HPCSA legally and those kind of things. But even within our provinces, we can start those conversations, and I think it's important to get that ball rolling. But yeah, that's all I wanted to add, and I think we are sitting in the right positions to make those changes. It just starts with the advocacy part. Thanks, Caleb. Sorry, I get carried away.
No, thanks, Louis.
Thanks, Louis.
I fully agree with you. And if I can just pick up on that point that you make about asking the patients, what do you want from us? That is so key. We are a service. It's in our name, right? Emergency medical services. Maybe it's time we start acting as if we are a service instead of as if we are God's gift to every patient that we come across, and get rid of some of that attitude and actually approach them and say, hey, I'm here to provide you a service. What would you like me to do? Let me see how I can best achieve your goals.
Caleb, I think you muted yourself. Or did I miss?
I was finished.
Oh, sorry, I'm being off today. I don't see any other massive questions, but there are just a whole lot of comments just around system change and perseverance and just having to keep push the narrative. If there's anyone who has a question or a comment that hasn't put into the notes or questions, please feel free to pop your hand up while Caleb is available to chat. Pierre's asking for a 4-hour interaction, Caleb. So when you're ready and you've got some time, let's figure it out.
I could probably do that. So if you
can
want
probably go for days, to be honest.
Yeah. No, it's a great topic. You really can dissect this in so many different directions. So I'm happy to have any more conversations in future.
Awesome. And I think we picked this up with the previous interaction. This is just the start. So keep a lookout. There will be, I think, quite frequent palliative care conversations happening on this platform. The intention is to make ourselves and our systems better and to treat our patients with exactly what they need and want from us. So this is not the last time you're going to hear from Caleb, for sure. Cool. Just a few people asking for your email address. Caleb, are you happy if I pop that out on the platform?
Oh, yeah, sure. I've actually just typed it out myself here.
Okay, great.
Drop it there, yeah.
Awesome.
Yeah. And then
Thank you.
I'll email you the slideshow as well if anyone wants access. They can also go there. So
this is also a sponsored Coffee and Cases. So the presentation will be available on the YouTube platform for anyone to be able to access. So I'll send out that link as soon as it's available. Awesome. Thank you guys so much. I see Bianca's hand was up. Bianca, did you want to ask something or say something? Bianca? Cool.
Good morning, guys. Sorry,
there we go.
myself there. Morning, Mr. Kate. Morning, Caleb.
Hey,
just quick. a BLS ILS perspective, while I was at Netcare, Mr. Stanton and I had the fortunate luck of treating 13 palliative care patients. And yeah, so just from my side, just a chat with the family to explain that the patient is in, the last phases of actively dying, so forth, has made a huge difference in the way they approach things. And then from my side, I just always consulted with Mr. Stanton that the family has agreed to do palliative care and allow the patient to pass away at home. And the biggest issue I always experienced was the LSs with pain medication, because everyone wanted to transport the moment they gave pain meds. Is there any way that there's an approach to, I don't want to say educate an ALS, but to handle the situation a little bit better, that there's not that unseen back and forth? If I gave pain meds, we have to transport.
Thanks, Bianca. Yeah, and good to hear from you. So you raise a couple of things there. The one is that, yes, it's so crucial that we include family members. That's why they are included in part of the palliative care definition. It has been described as one of the greatest forms of suffering is to watch a loved one suffer and to watch a loved one die. And you can imagine that, and perhaps some of you have experienced that yourselves. And so we have to take them into account. We cause such great harm to them by ignoring them or not including them and so on. So that really, really is crucial, and it does make such a massive difference. And it's also meaningful to us. It makes a big difference for us as well. In terms of the transportation issue, I stand to be corrected, but I do not believe there is any legal framework which indicates that once you have administered a medication, you must transfer a patient to the hospital. There is no such thing. That has simply just become this EMS policy, and I think largely has to do with billing, which may be fair enough or not. So that's one of the ways where we need to, number one, relook at this EMS policy to say, why are we actually doing this? And should we be doing it in these cases? Sometimes the answer is no. And then the second thing is this also relates to the funding. How can we allow EMS providers to provide the necessary care on scene, including providing some medications, without transport, while still being able to bill for that call? So that's something that does need to be worked out. And that's why that is mentioned in this framework as a way that we can truly integrate these services. So I know perhaps not a definitive answer, but that's the thought process behind that. Sorry, I saw that question in the chat. So with regards to the medication, would it not put us at legal risk if we had to give the pain medication and not monitor thereafter? So also a very good point. And that is the challenge, and I think that's why this policy does exist. But what you raise is a great point. When we talk about maybe managing a palliative situation at home and leaving the patient at home, this is one of the crucial things, is that we don't just leave them. We need to link them with care. We don't just abandon them. We need to link them with the appropriate care. So let's say you've administered a bit of subcutaneous morphine to relieve some dyspnea or some pain. You can, in an ideal world, you would then be able to phone a palliative service provider or home care service provider that you are in connection with, and then they can later on send one of their home care nurses, for example, to come and follow up on that patient. Alternatively, you could do follow-ups on the phone, the telemedicine approach. So there are ways to mitigate that legal risk.
Sorry, I got myself confused on a phone call. I think we've answered pretty much most of the questions. So I think the last thing we need to just say is thank you very much, Caleb, for your time today.
Yeah, thanks so much for having me, and thank you everyone for the great questions and discussion. Yeah, please feel free to email me if there's any more. Happy to engage. Thank you.